I'll point out too that we asked our list of primary care physicians in advance for questions, so some of these may come from there in advance of the discussion. Okay, the first one is, my female patient with PV was told by her previous hematologist to get a phlebotomy for a hematocrit greater than 45%. Her new hematologist recommended greater than 42%. How do you coordinate those two when they're getting that information, and which one should I use?
So that's a great question. The data for the exact percentage of safety for phlebotomy comes from an Italian study where patients of all genders were randomized to keeping their hematocrit under 45% or under 50%, somewhere between 45 and 50%. And that was accomplished with both phlebotomy and, in some cases, hydroxyurea. The practice of using a lower hematocrit level for females is not supported necessarily by that randomized trial. But we do know that, in general, females have a lower hematocrit level than males. And so it's a really practice by practice idea of what to keep it. I tend to keep my patients in the 42 to 43% range, knowing that, some days you can't schedule the phlebotomy for another week or so there's always some flexibility. There's no absolute magic to the 42 to 43. I'm interested in the practices of the other patients or the other providers on the panel, though.
Yeah, I totally agree. I think that trying to keep the hematocrit below 45% at all times is very important, as supported by a randomized clinical trial. The problem is that you're not checking the hematocrit each and every day. So let's say your patient is 44.5, and so I do think that perhaps getting a lower level so that you can ascertain that the hematocrit while you are off phlebotomy is always below that number, but again.
Do you keep women at lower levels than men?
No, I don't actually, but it's actually a good question, and whether or not they are having symptomatology or symptoms, if their hematocrit is above 42%, I mean, that probably merits additional investigation, but I haven't seen that in my practice, so I keep them, yes.
I think some people are just more symptomatic, and so we can aim for 42% with them, but I haven't really noticed a difference between men and women in terms of that, so I just aim for everyone has to be less than 45% according to the CYTO-PV study by Tiziano Barbui and colleagues, and then 42% for people who are symptomatic and have erythromelalgia and other symptoms.
I was just going to add in, as we've looked at some of the data as it corresponds to hematocrit and symptoms, I think what Kat brought up is exactly correct. There's two things. One is trying to prophylax against vascular events. And two things, the second is really trying to optimize how they feel. And they're not necessarily exactly the same thing as it relates to risk of vascular events versus symptoms. So it should be individualized. There clearly are some men who clearly do feel better at a slightly lower number. So I don't think that it's overly gender specific. The origins of these numbers, I think, were a bit theoretical, in terms of the numbers, as opposed to any sort of randomized study in terms of the amount.
Next question. Boy, we got some good ones, I have to say. Okay, my patient is asking me to repeat the JAK2 testing. Is there any reason I should be doing that?
I think so. One of the slides I was going to show was Peter Campbell's paper with Tony Green in the New England Journal from a couple of years ago, where they show that the variant allele fraction or frequency matters. So often when we've tested patients, we just say yes or no, they have the JAK2 mutation. But because now we know that the level of the JAK2 mutation matters, I think it's important for prognostication. So we heard about that for thrombotic risk if you have a JAK2 mutant allele burden, but it's also associated with a higher risk of progression to AML. So now we do next generation sequencing, and I imagine most of the centers around the room, whether it's University of Chicago, Stanford, Mayo, UT San Antonio, Columbia University, Cornell, I think just about all of us are doing next generation sequencing and looking at the VAF.
Okay. Kathleen?
Anyone? Okay. My patient with ET has normal hemoglobin levels and concurrent iron deficiency. Should I give them an iron supplement?
No one knows.
Answer that, I think my concern would be that this patient may actually not have ET, because that's always my concern. People who present with isolated thrombocytosis, but they may be iron deficient and hence don't meet the criteria for the hemoglobin or hematocrit required for a diagnosis of PV. So without knowing the bone marrow biopsy, I think giving iron supplementation could be problematic, particularly if you're missing that diagnosis. So that's my take.
You have to make sure, though, that the patient actually has ET, that it's not just a presumed ET that they've been carrying around from some physician that it was never validated. So I see that sometimes a patient who comes to me with a diagnosis of ET who's profoundly iron deficient, but the real problem is profound iron deficiency, which has given them thrombocytosis. So that's one of those cases that you really have to investigate, that you have the exactly right diagnosis.
So back to stem cells. The reason that happens is when we're iron deficient, we can't make red cells from megakaryocyte erythroid progenitors, but we don't need iron to make platelets. So that MEP makes a ton of platelets. So that's a more common cause than ET.
Okay, I know there are others in the room also that if you'd like to jump in or say something, you're welcome to do so. And in this question, there are a few that might. When do you have a conversation with your patients about transplant?
A tough one. You know,
If you have that
I remember rounding with Jason on the inpatient service for BMT, blood and marrow transplantation. And, you know, I think for myelofibrosis, it's been woefully disappointing because mortality rates for fully ablative transplants are in the range of 40 to 45%. Graft versus host disease rates are higher. So then you think, okay, we can do a reduced intensity conditioning transplant. We used to call them mini transplants. There's nothing mini about them. Mortality rate in the first year is 10%. Graft versus host disease rate is 0%. So then you take somebody who's got problems with some fatigue, you know, abdominal pain, and you give them something that causes chronic diarrhea, dry mouth, sloughing skin, and what do you use to treat it? Jakafi. So you take them from Jakafi, which they were on pre-transplant, to, oh, now you're going to need a post-transplant. So I really think we've got to question the use of transplant unless patients have a high molecular risk. So we can do the MIPS Mutation-Enhanced International Prognostic Scoring System Plus, where we take into account the level of fibrosis and their mutation risk. And if they have high mutation burden with high-risk mutations and they've got more extensive fibrosis, that would probably be the patient to consider, especially if they're younger with fewer comorbidities. But those patients are rather rare. And so I think we've got to consider we're replacing one disease for another in the majority of patients that we're transplanting. So we really have to think, what are we getting from transplant? We're trying to do a graft versus MPN effect, or graft versus myelofibrosis effect. The graft versus myelofibrosis doesn't work very well. If you've got a scarred down bone marrow, those stem cells that you get from another individual want to go to the spleen. Splenectomy doesn't help because then extramedullary hematopoiesis just occurs in the liver. So these are really important considerations for patients, especially when we're talking to young adults who are considering it just because they've been told you're younger, you need to get that. So I think it's a pressing thing, but the good news is we have so many tailor-made immune-based therapies now. We can start looking at natural killer cell therapies, directed T-cell therapies that look at neoepitopes. I think we can do a more refined or bespoke kind of cellular therapy for patients.
Anyone else?
I think that's a really important point, that before I send patients to transplant or even think about it, we really are in a moment where we have more new therapies to look at to treat these diseases than ever before. You know, whether we have targeted therapies or we have immune-based therapies, certainly it is worth trying some of these new therapies, I think, on clinical trial and referring patients for clinical trial before you think about definitively sending them for a transplant.
Anyone in the U here?
Well, as probably one of the few transplant physicians sitting around the table, I probably have a slightly more optimistic view on it. I do think that patients can benefit from transplant. Of course, it's a shared decision-making process. Not everyone who comes to transplant consultation necessarily should get one. I think that, despite all the really promising drugs that are coming around, I still don't feel like we have a curative option, and transplant can provide that. I think our rates of GVHD definitely are there, but I can think of a number of patients who also get back to a pretty regular life after transplant. Their marrow doesn't have fibrosis anymore and has the cells in it. So I think that it's certainly not a treatment for everybody. It's something that there needs to be a very careful discussion about the risks and benefits. But I also think it certainly isn't something that I would necessarily consider definitely trading one disease for another. I feel like there's a lot of patients who do quite well with it, and especially looking at how some patients progress with myelofibrosis. If you wait too long, then it won't work, and then they will have a very poor outcome. So it's one of those careful timing things of where do you draw that line, and where do you say, okay, we really should do a clinical trial versus, oh, we really should do transplant. And I've had patients who say, well, let me try this clinical trial first, see if it works. If it works, great. If it doesn't work, then they go to transplant. And so I think that they don't have to be mutually exclusive either.
Taga, do you have anything to add to that?
So I'm one of the transplant physicians here. So I think in general, I agree. Just going back to the question that was asked, when the patient should be referred. So from my side, I'm
That
only
doesn't-
seeing them once they are
right,
referred.
right.
But I think especially for younger patients, I think early referral, at least for discussion, may be warranted. And we also don't want to see them when they're rapidly progressing accelerated phase MF going into AML. That's probably a bad timing. So we would like to see them when they're more stable.
The other thing to address the timing of when to refer, I always think that they should come and see a transplant physician earlier in the process than they need the transplant, because undergoing a transplant takes an enormous stress on a patient's resources, financially, socially, physically. And so I think it's good when you can sort of advise the patient, this is what would be coming if and when you proceed with transplant. And then when they do proceed with transplant, they can have all their ducks in a row so that they're not putting themselves in a dire situation financially, personally, with regards to childcare. And I usually try to give patients a good year, because I follow many patients with MPNs by them, that are not transplant patients. And I usually say, we're probably looking at transplant in another year or so that they could say, well, geez, my child's going to graduate high school, or somebody's going to get married, somebody's going to have a grandchild. And I try to usually tailor it around important events in life, but you can't do that unless you know the patient ahead of time and are able to sort of help them prepare for what's coming.
Just to follow up on that, I think now that we're doing the MIP70, we're looking at, the level of fibrosis in the marrow and the risk of, or the higher risk mutations. Usually what I try and do is see if we can have a combined strategy to reduce fibrosis if possible. Now, I know a lot of people think that's impossible, but we do have a couple of agents that do that. We've got Inrebic, as I mentioned, that seems to reduce it in about 25% of patients based on an earlier phase study. We've got Navitoclax, which actually looks pretty exciting. We didn't mention, but that's a BCL-XL, BCL2 antagonist. So I think possibly interferon combined with ruxolitinib. So I think that there are some interesting ways to potentially reduce the fibrosis so that the chance of engraftment is higher.
Okay.
How about one more from each and then we'll break? Because we've got a lot of them to come back to. Is that okay with everyone? One more from Kathleen and one from me?
Okay.
Oh, sorry, did I interrupt you?
No, that's all right. Should families of MPN patients be screened?
Angela just walked in the room, so should families of patients with MPN be screened?
I think at the present time, there's no rationale for screening them. I mean, there's clearly a familial predisposition to acquire a myeloproliferative neoplasm, and what I usually tell patients is that they shouldn't have their first-degree relatives just screened just to be screened. But however, if they had any suspicious CBC abnormalities or had a blood clot, to have one of the first things they tell their physician, my mom or my sister or somebody in my family has a myeloproliferative neoplasm, do you think it might be helpful for me to be checked? But in the absence of any red flags or anything that would make one suspicious that somebody has a myeloproliferative neoplasm, I don't think it's probably, at the present time, should be screened.
Yeah, I would agree with that. This is Jason. You know, we talk about the incidence of MPNs being around 2 in 100,000, and we know of inherited germline variations that will increase that risk by 3 to 4-fold, which sounds like a lot, but that really is taking the risk from 2 in 100,000 to 8 in 100,000. So although there's a multiplier effect, the absolute risk within families is still very low. So as a matter of course, we don't recommend routining for MPNs and other family members.
I just wanted to make one comment. There is a very rare cause of ET with familial germline MPL mutation, so that would be the exception. We've had a family, and we made the diagnosis of an infant who was born to a mom who had that, but very rare.
Yeah, there are rare non-canonical JAK2 mutations, not JAK2 V617F, but JAK2 V617I, which is found in essential thrombocythemia. These are exquisitely rare. So if you have a non-traditional MPL or JAK2 mutation and there's a family history, that might, I would think, increase the interest in whether that might be a Mendelian inherited mutation rather than some type of germline variant.
I think it's important to state the difference between a myeloproliferative neoplasm and a hereditary erythrocytosis or thrombocytosis. I think what the question was asking is screening for a myeloproliferative neoplasm. And so that's the answer that we gave, but you gave an answer about hereditary thrombocytosis.
I'm Radek Skoda from Basel, Switzerland. So I think key is a good family history, and that includes asking patients about hematologic diseases in their father, like cousins or relatives. And if there's a second or third case, that is usually a very good indication that there is familial predisposition. Now, whether then to test the whole family or not, that's a more academic question, because knowing the predisposition per se does not provide a direct therapeutic consequence. But there are families that have a much larger increase in the risk. I mean, there are large families that have like 500-fold increase. So there is a big difference between different families in terms of their increase in risk of acquiring MPN phenotype. And that stems from what you have cited, threefold increase in the case of the JAK2 variants, but some of the families have actually a dramatically increased. But these, on the other hand, are very rare. So I would say that the most important is at diagnosis to ask a very good family history and include relatives that are farther away.
I just wanted to mention one case, or a couple that I was looking after, a mom and a daughter, where the mom had the calreticulin mutation, and I picked it up by PCR and never done next generation sequencing on her, and she said, I need you to test my daughter. And I said, I can't. Why would I test your daughter? I said, the likelihood of her being calreticulin or any MPN mutation positive is very low. And she said, well, she's got ovarian cancer, she's getting chemo, and she's really bottomed out her count. So I think she may have what I have, myelofibrosis. I said, I think that's extremely unlikely. I did the next generation sequencing, and her daughter had a different CALR mutation. So I went back to her mom, and we did next generation sequencing in her mom, and her mom had both CALR mutations. So she really did get one allele from her mom. And she also had the BRCA1 mutation, and she recently succumbed to her ovarian cancer, the 41-year-old daughter. So that's why I'm bringing up these may be potentiators of solid tumor progression. So, I try never to say never. I said never in that case. So I was really cursing myself because I said that'll never happen. Well, it did happen. But what I'm seeing more often are KMT2C mutations, DDX41 mutations, other epigenetic modifier mutations that I'm wondering if they set the stage for getting the JAK2 mutation or just having more genomic instability. So I'm wondering if anybody else is following those people that have a variant allele fraction or frequency of about 50%, where it looks like it's inherited. Radek, have you looked at that, or who in the room is seeing this? Because I'm just starting to see it more.
So I think you have to distinguish between the inherited predisposition, and there are Italian series from Mario Cazzola and other labs who have systematically asked a patient a diagnosis, and sort of the familial predisposition is much more frequent than we would assume. So it's in the range of, I don't remember exactly, don't want to say exact percentage, but it's much higher. And that's based on cases where you have two close relatives. Now, some of them may be just by chance, but if you have three in a relatively direct relationship, then the likelihood that that's just by chance is practically null. And we can very easily distinguish between a mutation that was inherited through the germline and an acquired mutation, and I think that would be the first step in such a case when you have a daughter and mother with the exact same mutation. I'm not aware of germline calretical mutations yet, but it would be kind of interesting to see if one of these mutations may be germline. And so I think it is more frequent than we think, and the predisposing gene, as we think about it, is providing sort of the fertile ground for the mutations that occur spontaneously to expand. And the actual mutational risk that we have for acquiring a JAK2 mutation is considerably high, so probably most of us during our lifetime acquire this mutation. But in the very large proportion of patients, this mutation does not expand, except in cases where maybe some of these germline predispositions favor such an expansion, and then many other factors that can promote the expansion. And many of these families of predisposition actually have the JAK2 mutation in some family members, and the calreticulin mutation in the same family in other members, and there are even cases where you find the MPL mutation. So all the classic mutations that we find in sporadic, you can have in rare families with predisposing mutations. And of course, the germline Mendelian mutations, they are very easy to spot because most of these are present already in the children. They are usually high penetrance, and in general, they affect only one of the lineages. So you either have high platelets, high red cells, but very rarely both.
So how about one more question and then the break? This is from a primary care physician. He says, should I be the one prescribing meds for side effects, for example, neuropathy or itching?
Say no, that if the oncologist or hematologist is prescribing a particular medication, they really need to know what the side effect is that the patient is experiencing and needs potentially to either change the underlying agent or modify the underlying agent or to give medications for symptoms. So I think that's one example of where a good conversation needs to take place between the primary care physician and the oncologist hematologist, because it could be that they forget to tell you when they are at a visit, but may remember to tell the primary care physician something. So again, it's an argument for being in close contact.
I think, I'll just reinforce that I think communication with the primary care physician and the cardiologist, everybody is really essential because, I've had patients show up and say, oh, well, I've been on antibiotics for 4 weeks for this ulcer I have on my ankle, and, or I'm going to surgery tomorrow. Those are the things you need to know in advance because, and I think we can really collaborate with PCPs better than we do.
I was just going to add, I think that issue of communication is just so essential because there's just so many ways for, each party to think that the other one is really addressing it. And neuropathy kind of being a good example. For most of our MPN patients, we really don't expect neuropathy as a side effect. So is that a sign of a different problem? Perhaps. It's a bit like the issue of worsening anemia. Where, again, I've seen patients where their home physician thought that the worsening anemia was clearly related to their blood disease, and it was actually related to iron deficiency from blood loss from an undiagnosed colon cancer. So again, there's lots of ways that the lack of communication, things can kind of fall in the cracks because each side thinks that the other side has it dealt with.
And I would just add that now that we have a fair amount of patients on JAK inhibitors and we need to surveil them, for example, the issue of checking their lipid panels perhaps every 6 months, making sure they're getting their yearly dermatologic exam for that increased risk of basal and squamous cell carcinoma, making sure that they can get their 2 shots of the shingles vaccine, the kill vaccine, which is, last year or 2 was hard to get, now more available. That's where we can engage the primary care physician and get their help with that.
It's a great segue for a break because the next conversation, the big question here a couple of times is how do we communicate better with the primary care or the hematologist and form that relationship early on? Thank you.